next we have a panel discussion based on a topic that were discussed before. As a moderator, I invite Dr. Ullas Batra from Delhi to moderate the session.
Good afternoon, everyone, and sorry you will have to bear with me for the next 1 hour because I'm standing in for Prabhat. I'll try to do half the good job that he tries to do. And for the panelists, can I please invite Dr. Aman from Nagpur, Dr. Vijay from Bangalore, Akhil from Varanasi, Dr. Suman Mittal from Raipur, Dr. Dilip from Kochi, and Dr. Tripti Pai from Mumbai. Since it is my slides which were made yesterday night at 2 o'clock, there is no one joke in this. There is no my initial reaction, no my final reactions on this. We will start with Seedhi Baat, no bakwas in this. And heartiest congratulations to Amit, having seen it is how difficult it is to publish our data. I mean, you know, it is not only, first of all, you should have patience. After that, you should have the zeal to, you know, write something. After that, the data has to be collected. It has to be sent. And if you have an editor like Vanita, it is a nightmare, you know. And to really publish, heartiest congratulations. It's a fantastic effort. And I think everybody who is here should try to publish more and more. It actually looks very, very good because when I was looking at the Lorlatinib data, I saw Amit's presentation, I saw Akhil's presentation. So it is nice. It is nice to get data out of your own group. I mean, so I think as youngsters over there, old people here, youngsters should take the lead and we should actually write something on that. Okay, so this is the systemic efficacy data for ALK. If you look at Crown trial, if you look at the ALEX trial, if you look at the Brigatinib, Crizotinib data, the HR actually comes way down, and we have actually seen that you know, Lorlatinib is far, far, far better. This is the most defining slide for me actually, and whenever a patient comes to me, I actually tell him, congratulations, when somebody actually gets diagnosed with ALK, and we tell them, you know, you can actually throw a plane through the gap. And this is what I tell them, you know, congratulations, you have an ALK-positive disease. At 5 years, 65% of people, 60% of the people are still PFS free. A median PFS has not been reached at 5 years. And imagine ALK with Crizotinib was only 9.1 months. So this is something which is very, very, very nice actually. So I'll start with you, Dr. Saman here. Are you convinced with the only the efficacy data of Lorlatinib in the first line setting?
Yes, very much.
Very much, fantastic. Convinced with the data? Convinced with the data? We will only do IHC and V1 and V2, and we will say that we will come to you on that. Okay, so I think as a group, we are all convinced with the efficacy data of Lorlatinib. But let me, and since it is not a Pfizer-sponsored symposium, let us say, let me be the devil's advocate. I will show you some graphs over here. You looked at this graph where I showed you a beautiful picture over here. But you also should see some more graph. Not all patients will respond to Lorlatinib. So out of all the 40-50 patients that we have given Lorlatinib till now, there have been 4 or 5 who have not responded. And then they come and tell me, sir, aapne to congratulations bola tha. I said, bola to tha. So we need to temper down our expectations also. Not everybody will respond over here. Can we somehow identify the early progressors versus the late persisters? I mean, I think that is a job for the molecular pathologists to really differentiate amongst the two. What after Lorlatinib? You know, I mean, I was seeing the presentation. After Lorlatinib, 61% of patients actually got Alectinib and Ceritinib and Crizotinib across the trial also. The point is, will all these drugs work? Yes, it is shown to be working, but still, we need to have more better understanding of that. What about the dreaded T word, the toxicity profile, and that is something which I am going to discuss in detail. And as Amit's data showed here, if it is such a good drug, then why not give Crizotinib, which is probably more patient cost friendly, maybe a new patent will go expire, something will come, and use Lorlatinib in the second line. So these are the 4 questions that I am going to pose to my panelists. So let's start with the first one. The patterns of progression with Lorlatinib and insights into subsequent anti-cancer therapy. This was presented by Tony Mock at WCLC. And if you actually look over here, see, look over here, how many? 20% of patients will progress within the first 4 to 8 months. So out of 100, 20% will not respond. And again, if you see, it is 70%. That is, at 2 years, 30% of people will not respond to this. So that is something which is very, we all look at, Pfizer tells us to look at this graph. What I will also like you to tell is that this curve. So it's not a very steep curve, but still 30% of people will not respond to Lorlatinib in the first 2 years, which is something which you don't really tell the patient. When a patient comes to you with ALK-positive IHC, I actually tell them congratulations. आपको इससे अच्छा कुछ नहीं हो सकता. But we need to see that. So this is almost like, Sunita Williams has not been brought back to earth. At least we should be brought back to earth, and say, okay, fine, 70% people will live. So what they did in that study was they basically found out that unconfirmed ALK-positive and TP53 mutation detected people were more in the people who do not respond to ALK in the first thing. How did they determine unconfirmed ALK-positive? This is here. ctDNA was either not applicable, not tested, or tested with no ctDNA detected. So Dr. Tripti, is this the right definition of unconfirmed ALK-positive? So ALK was positive by IHC in this study, and we also sent, the investigators would have sent a liquid biopsy. If the liquid biopsy was showing not applicable, people forgot to send sample.
No, you mean at the baseline CFDNA?
At the baseline, yes. So what is, in your opinion, the concordance between a liquid biopsy and a tissue biopsy ALK reporting? Difficult question, I know nobody will have the experience.
But thing is that in tissue you will have DNA and RNA based.
Correct.
Most of the labs, other than like Foundation One or Guardant, they are doing DNA based panel.
This would be either Foundation or Guardant. This is central lab testing.
Yeah, so that is basically the DNA based fusion testing that they are doing. So as of now, if you see fusion testing on CFDNA, there is no standard cutoff or anything. There are too many irregularities in that. So I don't know how they have actually said this unconfirmed.
So, and the second point, I'll come to that point, and second point is the TP53 mutation.
Yeah.
So one question which I'll ask from that side is, how do you test ALK? Is IHC enough, or you still go ahead and do NGS for your patients?
So I think nowadays we are doing NGS for every patient upfront.
Okay, fantastic.
So where I practice, it's done as a panel. So
You practice in Bangalore, if I'm not mistaken. So Bangalore is a high-tech IT city.
Yeah.
Bangalore is a city where Amit Rotan tells me they send liquid biopsy for everyone.
So we do, for adenocarcinoma of the lung, we do it as an in-house testing. So we send it as a panel. So EGFR, all-cross, they are all done as a panel. And if I ask for IHC, they say, why do you want IHC?
So you don't do. So you are not doing IHC, you are not doing IHC, ma'am?
Same. Most of the time it's a 12 gene panel NGS that is done for most of the patients. So ISC is not done most of the time separate.
Fantastic. So I think yes, Dr. Tripti, you had to come in on this.
No, I just wanted to say that there is a concept that if NGS is done and ALK is a part of it, 100% times you will cover that. So it is not, it also depends on what panel is used. So if it is amplicon based and a typical EML variant and ALK is covered, only then you will detect. So we have had cases in which NGS is negative, but done on NextSeq and Sophia panel and everything, and IHC is positive and patient has a stable disease on Alectinib. Later when we, then we found that there's a very unknown partner like Striatin. So even this happens. So in case if your fusions are not detected and very high suspicion, there is no harm in doing ALK-IHC later also.
I would totally agree. That is one of the reasons why we have not gotten away with IHC in our setting. A, because the report comes in 2 days time. Second, you are not dependent too much on the molecular pathologist, because with NGS, let us accept it as medical oncologists, we do not know the entire thing, and forget medical oncologists. Since not many molecular people are here, I can see with a molecular pathologist, the size of the panel, how much genes they are covering, how much fusion partners they are covering. We don't know. So to me, ALK by IHC should be the gold standard. Also, we should try to do NGS for them as a secondary part, because then you will look at the TP53, you will look at the PIK3CAs, you will look at the other thing, which will then help you to prognosticate your patient about the efficacy of Lorlatinib or Alectinib or Crizotinib. Is that a fair statement to make? So this is what my thing is. There are 30% of patients who will progress during first 1 or 2 years. So every time, congratulations is not the word. At least after looking at this data, I have tempered down by saying, "Aise अच्छी report है, 70% लोग अच्छा करते हैं." That's what I tell them. I don't tell them 100% लोग अच्छा करते हैं. And we need better biomarkers. Only P53 is not there. But a complementary IHC and NGS should be done for everyone. I mean, at least in places where they can afford and stuff like that. Yes, Dr. Tripti.
So in Tata, it is either a NGS or a IHC, and it is from the request from the physicians, but whenever possible, upfront NGS. Only some cases when we say that NGS is not possible tissue, that time IHC. But in that scenario, I wanted to say that even in such cases, if negative NGS, we should later, if available, we should do.
And also RNA based NGS. Only DNA is not enough. So that is
Very
also
true.
because for any fusions, you need to have a look at the RNA based fusion. That is one thing. Now, details of first subsequent antisystemic therapy, 61% of people who progressed on Lorlatinib actually got Alectinib, Crizotinib, Ceritinib, Lorlatinib, Regatinib. So that is also very, very important. In spite of that, the PFS2 was better in the Lorlatinib arm than it was in the Crizotinib arm. So typically, what about plan B? I think that's a very, it's a concern which is not really unfounded. How do you manage a patient on Lorlatinib? What do you do?
I usually do give chemotherapy.
Give chemotherapy. Any immunotherapy or the four
ABCP
drug?
very infrequently.
ABCP very infrequently.
No immunotherapy, I think.
No
chemotherapy.
immunotherapy, Dr. Saman?
Most of the time it is chemotherapy only.
I would agree with everyone. Ideally, we should do a rebiopsy. I think I was just being shown a report over there. Somebody on ALK has got a MET amplification as a HER2 new amplification also. Ideally, do a rebiopsy. But if rebiopsy is not possible, only chemotherapy. Generally, immunotherapy does not work in ALK rearranged non-small cell lung cancer. The immunotherapy plus bevacizumab also does not really work in this setting. That is the thing over here. So, the drug is too good to be true. You know, it works. 60% of people have not even had a 5-year, at 5 years, they have not even got a PFS on that. So, let's talk about the toxicity, the T word in toxicities. So, how has your experience, Dr. Saman, been with Lorlatinib, the toxicity profile?
So, lipid profile and CNS symptoms, these are the two main things.
Two main things that we are concerned about.
Yes, we are concerned
And
about most.
is it, how do you counsel a patient upfront to start with?
Same with that, it's a good thing, good drug, so you have a lot of benefit, but when things are too good, we have certain carry on with us, so we have to take care of those things with the drugs, lifestyle modification, maybe food modification.
Fantastic.
So we have to balance.
How was your experience there with ALK?
So when newly diagnosed, I try to go more in deep into his personal life, like his profession, whether how stressed he is, marital life, whether he's gone through any divorce.
Marital life, if you start asking for problems, they will come into your
No,
marital life later on over there.
It may matter because it depends
Zyada ho
on,
jayega, to both of you will go to a marriage counselor.
it may matter into his how he may tolerate
Correct.
the drug, and the cognitive effects also may be different, and people who are working in a stressful environment may not be able to.
Correct.
And I do tell them that this drug may cause such effects and it may affect your work, and most of the people who are ALK positive whom I have seen are actively working IT professionals, and they are under stress. So
And how has the tolerability till now been?
so far I have been searching for it, I have not found it.
Yeah,
The
but
hypertriglyceridemia and
which
weight
will
gain
happen
I
in
have
90% of people. That is absolutely okay. Same or something
Yeah.
else?
Similar only. I think the hyperlipidemia part is very well manageable with the statins. And the CNS symptoms also I haven't found it very frequently.
Okay. I will just like to, this is a graph which is very, very important, and if for all the young residents listening over here, search for an article by Todd Bauer, B-A-U-E-R. I mean, very nice way they have told about the management of side effects of toxicity profile of Lorlatinib. This article should be downloaded, it should be kept in your, next to your armchair whenever you are there. So this basically says, one, how many toxicities happen, and what is the timeline when the toxicities happen. So for the first 2-3 months, you will get, if you have to get hallucinations or some kind of mood swings or some kind of cognitive impairment, you will get at that time. Hypercholesterolemia, you will get within the first 2 weeks. I mean, I tell people 96% of the time you are going to get some hypercholesterolemia. Good
So
thing
if I
is,
may
yes.
add here, so
Yes, please.
the cognitive functions are first noticed by the spouse.
Are for the?
By the spouse or whoever
Yes,
is
yes,
staying
yes.
with. So
Absolutely right. So, I mean, I will come to the cognitive function. I will come to the cognitive function, yes. Okay. So, I will tell you a story on this. You know, I will always ask, बाबूजी या दीदी कैसी हैं, गुस्सा करती हैं? और द नेक्स्ट टाइम ही टोल्ड मी, अरे सर कितना गुस्सा करती है, पहले भी करती थी अभी भी करती है. तो नाउ आई हैव चेंज. आई सेड चलो पहले से ज़्यादा गुस्सा तो नहीं करती है. तो फिर मैं बोलता मारती तो नहीं है. So you know the levels keep on going on changing on that. Delhi, no, anything can happen over there. No. Bangalore is far more easier. Okay, so initially your cholesterol effects will come, then your side-by-side CNS effects will come. If somebody did not have a CNS adverse event by the first 3 months, very, very rare that the CNS adverse event will come in the later part. Major toxicity of weight gain, pedal edema, which is there, which to me is actually much more severe than cholesterol and all, which will come later on. And we have seen people who have increased around 10 to 20 kg weight also. So that is something now I have started telling them to do a salt restricted diet and do exercise and everything from upfront only. So that's the third side effect which I have been telling them very, very regularly. So let's start with hyperlipidemia. So the concerns with hyperlipidemia, Dr. Suman, people will ask कि इनका तो cholesterol पहले ही बढ़ा हुआ है. Everybody, I mean, at least the way we practice, all Punjabis have hypercholesterolemia, hyperglycemia and everything. So let's say you have a patient who has a grade 2 cholesterol is let's say 250, triglyceride 287. Will this come into your way कि उसको आगे कुछ cholesterol का problem, I mean cardiac side effect ना आ जाए, or you are okay with that?
No, definitely cardiac side effects and all the things which are associated with the hypercholesterolemia is always a concern. So, and we know it is early after we start the drug. So we have to start counseling and lifestyle modification, maybe early introduction of the statins, at the same time managing the stress, and all these things are very important, so that while we are taking care of the lung cancer, but at the same time, other comorbidity should not be increasing.
So, Dr. Vijay, I'll ask you, will a patient who has already a deranged lipid profile, will you start that patient on Lorlatinib or not? For the fear of, money is not an issue, for the fear of cardiac side effects.
Most of the time it will be mildly deranged in my experience, and I do go ahead and tell them that they have to proactively manage it, and it often gets managed.
So I'll just come to you. This is what, so the problem with hypercholesterolemia is it a paper toxicity or is it a clinically relevant toxicity? So what they did was they basically found out that with longer follow-up and longer exposure to Lorlatinib, the cardiovascular AEs did not increase, and the second time was, although more people with Lorlatinib had hypertriglyceridemia and hypercholesterolemia, the cardiovascular AEs were actually lower with Lorlatinib than with Crizotinib. Because the more significant side effects with Crizotinib were with the thromboembolism. So that was also included. Second, most of the patients were already started on statins. So ultimately what they found out is, even if you had a grade 1, grade 2 lipid profile to start with, it did not make a difference. At least a 5-year follow-up, there was no increased rate of a cardiovascular side effect, and that's okay. But as everybody has rightly said, you need to educate the patient. And again, a standard statement which I say for the patient is, what is good for your heart is good for your cancer. So don't take oily foods, do be physically active. That is one statement which I normally say, and that is what actually goes on over there. How do you manage hypertriglyceridemia? What is one drug which you will use? What is one drug which you will not use? And then we'll come to the marital side effects and everything of Lorlatinib.
So I would start with a statin.
With statin?
Mostly rosuvastatin.
Correct.
I would start with.
I mean, again, absolutely fantastic point. Start with rosuvastatin. Please don't give atorvastatin. Atorvastatin is one drug which has actually got contraindicated because it's got drug interaction profile. Normally we start with rosuvastatin 20 mg or 10 mg or 20 mg. Then add a fenofibrate. Maintain a level of around a lipid grade 1 CTC around 200, 250. That is what we do expect. Is that right?
Correct.
Okay. Fantastic. Now, this is something called as the most importantly the chemical locha that happens with Lorlatinib. Initially when Lorlatinib was introduced, actually I felt everybody was jumping off the floor and everybody will go to the psychiatrist and become pagal. So that is what was actually our thinking. So since we take a very detailed history about the, okay, before I do this, what Dr. Vijay said was absolutely right. For the cognitive effect and for the anger issues, because you will be talking to the patient only for 4 minutes. And if there is some problem or some guy who comes and tells me, is there a problem with me? I'll obviously say no. If you ask my wife, is there a problem with me? She'll tell you for 2 pages, yes, there's a problem with me, right? So you need to talk to the spouse, the parents separately, and we do educate them that listen, this drug can cause anger management issues, behavioral issues, slowness in this thing. If there is an issue, come back and tell us. So what he actually said was right. And but again, you know, this very sensitive conversations that you have. Okay, tell me.
So, sir, when I first heard about the suicidal tendencies, so there was one famous movie where a doctor is implicated when his patient committed a suicide or a murder of spouse. So I was very much influenced. But however, the data shows that progressively Lorlatinib is more effective, and also the side effects are well managed with dose reductions.
Okay.
And if we proactively monitor it, it will be.
So what are the major CNS side effects that you have seen with Lorlatinib? With CNS side effects?
Basic, more of somnolence kind of this thing is what I have seen more.
So again, this is which was there. First of all, the CNS side effects will come within first 3 months. So implication of that is, normally with oral medicines, we call the patient only once in a month or something. With Lorlatinib, please call them twice a month to start with for the first 3 months till the time you do a scan. That is the first important thing. Do a lipid profile, call them every 15 days. The first 3 months are the most important thing. Call them at that time, talk to the wife, talk to the husband in detail and ask them about that. The incidence of CNS AEs actually does not increase. Most of the CNS adverse events do not require any medical intervention. So what I also do is when a patient comes to us, we will tell them, listen, इससे थोड़ा mood change हो जाएगा, गुस्सा ज़्यादा आता है, कुछ होता है, दवाई बंद कर दीजिए. Once they stop the medicine and they take your appointment, by the time you come, 48 hours would have already passed. By that time, the mood would have actually stabilized. So the first thing is at that time only you tell the patient, if there is a side effect like this, change, stop the medicine and come to us. Having said that, there have been a couple of people who have actually been overthinking about that, and the patient has also landed up in the psychiatric ward, but very, very far and few in between. Most of them, you just stop the drug, and you ask them to call, and then you restart the drug at a lower dosages. A lower dosage, I mean, be absolutely okay in starting the drug at a lower dosage, and that should take care of this. If it doesn't work, you can probably give us some kind of mild sedative or an SSRI. That's absolutely okay. Yes, Akhil, you want to make a point?
Sir, have we created any sheet, a counseling sheet for the patients? So
Yes,
that's
so
very important.
yes.
So we attach a Lorlatinib counseling sheet for every patient who is being started on Lorlatinib.
Correct. And actually going forward, since there are not many patients on Lorlatinib, it is always, you will always have a counselor in your hospital. It may not be a bad idea just to send them for a counseling, and we tell the counselor to tell the patient that, you know, these kind of side effects may happen, and if there's an issue, please come back and tell us. So that's also very, very important. But the important thing is, stop the drug, restart it one level lower, and absolutely nothing really happens on your nerves. So, Lorlatinib is second. Yes, yes, Dr. Zipli.
Like seeing so many side effects and difficult for follow-up, how feasible it is in a routine scenario in like India, for example?
It is not difficult at all. The drug is, the efficacy is still that good. And this happens only 3 to 4% of people. It doesn't really happen that commonly actually.
So like how frequently in first line do we start on Lorlatinib?
That depends on the cost. I mean, for me, 85% of the times I'll start on Lorlatinib, even if it's not a Pfizer-sponsored symposium.
Oh, okay.
And the Roche knows it very, very well.
And what about Varanasi?
Varanasi, how much? I will show you the data in that symposium about how much ALK do we. Okay, I'll show you here only. So this is the data that came from the TMH group, and you know, a median PFS in second line of around 16 months and overs of 22 months. This is our data which we showed over there. So this is what the difference actually is. If you give Lorlatinib over here, here it is. This is second generation data. This is only chemotherapy. So if you give chemotherapy, your median OS is around 40 months. If you give second generation to start with, it is 61.5 months. But if you give Lorlatinib, it is somewhere over here. Some more interesting data which come over here is we have actually analyzed the data by TTF1. So if you are TTF1 positive, you will do great. If you are TTF1 negative, you will do better than chemotherapy. But the data is absolutely this one graph which is there. This is also something important. Intracranial progression. This is Lorlatinib, the one which is the same graph. This is second generation and this is first generation. So Lorlatinib actually prevents against the, so this is the cumulative incidence of ALK TKIs which gets. This is also important. This is the evidence which I wanted to show. This was our cohort in 2013-2017. This was the median OS. Then we started moving to second generation. This is the one. And now we have moved over to Lorlatinib, and that is one. So if you know the drug, you should, and give the drug properly, explain to the patient properly. You can have the best of both the worlds. You can give the best drug, and you can educate the patient about the toxicity profile also. So anybody, you want to start with Crizotinib and then go to Lorlatinib, or you're happy with, and this is not a Pfizer sponsored symposium, that Akhil will do.
So definitely if economy is not an issue, so definitely Lorlatinib first, but many times, at least in our place, we do face where patients do not have any money, so we have to start with the
With Bangalore,
Crizotinib.
people will not ask about the money.
Yeah, but we need to ask.
With you, I will ask, yes. So what is your proportion? How much, are you sold on the science of that?
Yes, sir. Lorlatinib, yes.
I think fair enough. So, okay, this is also the number of data that we got. It is not the number of lines actually that the patient receives which will determine the survival. It is using your best drug earlier and better. So that is, my statistics guy asked me, sir, अगर किसी को 4 बार लगा है तो उसका OS बढ़ेगा, ऐसे नहीं sir. अगर आप अपनी best drug पहले दोगे तो probably that will actually translate into a more better survival advantage than this. So this is also which came out from this. This is the last 2 seconds. This was a drug which was Lorlatinib, which was compared with Crizotinib, and one more drug which was covered with that. Again, these drugs are Chinese drugs, they are well-made drugs, so he is telling me not to discuss. The only thing which is coming out of this is, why is Crizotinib the favorite whipping boy of ALK-related non-small cell lung cancer? Any drug comes, you will, Crizotinib ko leke uski band bajate rehte ho. So Crizotinib should be renamed as Mandir ka Ghanta. जिसको आते हो बजा के चला जाता है वहाँ करके I think they should
not even think of a protocol amendment, because I think when most of these studies were going on,
yes,
second generation drugs
so this for me is Crizotinib, and I am so glad that Pfizer is not looking after it. So my conclusions here is Lorlatinib is very efficacious. However, it has a unique and different safety profile. All practicing oncologists should be aware of this. However, 30% of patients will still progress within the first 2 years. We need to do NGS, we need to identify these biomarkers early. We need trials which compare a second generation followed by third generation versus the sequencing strategy. The benchmark has been set high, but ye dil mange more. So with this, I hope the Alcova trial and the next trials which are coming up will give us more answers. But even till then, I think whenever a patient gets diagnosed with ALK-positive IHC, my only word to them still is congratulations. Only I say 70% of people will respond well. So with this, thank you. Thank you for being a sport and being very nice panelists. Thank you.
Thank you, sir. You stay on the dais. So next session is sponsored by Roche, and this is a panel-based discussion on role of Tecentriq in lung cancer. Moderator is Ullas Batra, sir. Woman, sir. I request the panelists to be on the dais. Dr. Satyajit Pawar from Pune, Dr. Harsh Sahu, myself, Dr. Chandrakant, Dr. Pradeep Ventrapati, Dr. Shailesh sir. In the meantime, let's have some inputs and discussion with our DM and DNB residents. So what is the peculiarity of small cell cancer which differentiates it from multiple other cancers? Small cell cancer, what's the most important differentiation? Chemosensitivity. So it's a chemosensitivity, but is it a radiosensitive disease as well? Yes. So radiosensitive diseases are most of the time chemosensitive as well. Take example of, give another example. Yeah? Germ cell tumors. But if you see another example, like osteosarcoma, that is chemosensitive but not radiosensitive. So you should be understanding that it's not always true. All chemosensitive diseases are radiosensitive. What is the rationale that when you're doing a transplant, that means a rotation plasty for osteosarcoma, and you want to utilize the flap, the bone graft, so you are radiating it and utilizing it as a dead tissue. Anything, anybody is aware of that? Extra, ECRT. So what's the dose of radiation utilized in that? Anybody aware? ECRT dose, radiation dose? It's 100 gray actually. So 100 gray radiation is delivered to make the tissue dead, completely dead, and it's used as an implant. So it's a own implant being utilized as a dead tissue. So it's the best possible implant.
You can ask 2 more questions. देखें तो ये कितना आता है? देखो. You can ask them about durvalumab and stuff like that also, no?
नहीं. Drugs का नहीं. Drugs का सबको बहुत knowledge जा रहा है, एक साथ बहुत ज़्यादा knowledge जा रहा है.
मैं दोबारा email कर रहा हूँ.
अब एक और एग्जांपल लेते हैं. जैसे हमने डिस्कस किया लॉर्लाटिनिब इंड्यूस्ड टॉक्सिसिटीज़ का. अब इम्पॉर्टेंट हो जाता है कि काउंसलिंग. अब काउंसलिंग कितने पेशेंट्स के करे. अब क्या होता है कि वाराणसी में और टीएमएच मुंबई में ALK पॉजिटिव पेशेंट्स का हमने डे फिक्स कर लिया है. वेडनेसडे को सारे ALK पॉजिटिव पेशेंट एक साथ आते हैं.
अब I want to ask you, Akhil, does it work?
Yes, sir. So हम लोग क्या करते हैं सर, एवरी वेडनेसडे पेशेंट्स को ALK पॉजिटिव पेशेंट्स को एक्यूमुलेट कर लिया, उनके साथ टुगेदर काउंसलिंग कर ली.
No, but how does it help a patient?
So same group of patients, they are enrolled in Lung Connect program as well.
Okay.
So what is the advantage? All the ALK positive patients are coming together. They are also interacting with each other. For example, one patient has procured Lorlatinib or some other drug. We had utilized compassionate access program also recently. So advantage क्या हो जाता है कि same time पे same patients की counseling हो गई, and they are also interacting with each other. Which we were discussing. So basically, this is one of the thing which we are utilizing in high areas where there are high patient input. Same type के patients को एक साथ बुलाते हैं. EGFR के patients week में 3 days आते हैं because EGFR positivity rate at our centers is 46%. So out of 100 patients being tested, 46 are EGFR positive. This is due to NGS actually. Rare EGFR mutations भी detect हो जाते हैं. And at the same time they are being counseled together. अब हमने जैसे डिस्कस किया था EGFR के साथ में हम लोग co-mutation देख रहे हैं, P53 देख रहे हैं. कुछ और mutations जो नए mutations हैं जो are very important for us. STK11 for immunotherapy, okay. Any other mutation which you are aware of in EGFR? Anybody aware of PCC mutation? PCC? Yes. C helix, yes. Yes, sir. Woman, sir.
We were waiting for sir only.
Yes.
Okay, I think let's start now with.
Okay.
Let them get it over there. We will try to.
Two important mutations which I wanted to highlight. One is PCC mutation for EGFR. Another one is MTAP deletion. MTAP deletion is a very new mutation, and we are going to have a trial for deletion detection and then MTAP directed therapy as well. This is first time in the world actually, and thankfully India will be a part of this, and our center will be a part of this trial.
Okay, I think we will look at the. This is now the mic is not working. Okay. Has it come? Aram, has it come? Okay. So when we talk about the small cell lung cancer, it is actually the least preferred cousin, you know. I mean, I was just telling Dr. Vanita, you know, वो हर बार ना बोलती है ये टाटा का एलिमिना है, ये यहाँ का है, वहाँ का है. When it comes to Rajiv Gandhi, we are the small cell people. You know, the non-small cell are not Tata kind of alumni and AIMS kind of alumni. Rajiv Gandhi, other, you know, not so academic institutes are like the small cell lung cancer on that. But ठीक है, हमारा भी दिन आएगा. Somewhere down the line, we will also show good results actually over there. We will show you the cartoons later. So I have a case to start with over here, which you can see. It's a 55-year-old male who has come back with a lung mass. Okay, here is where we go. It has come. Fine. So this is, when we talk about lung cancer and small cell lung cancer, my first reactions actually are like this. Anybody can, Dr. Shailesh sir, anything to see in this, in relation to small cell lung cancer?
I can see the background small cell
Correct.
carcinoma.
See, that is exactly how I feel. So this is like the non-small cell lung cancer. This is all innovations, all pharma and everything which is there. And this is the small cell lung cancer. Somewhere in the background, wo last mein ladka baitha hua karta tha na, that were we. My subsequent reactions on that was, have patience. All things are difficult before they become better. And even the first ISRO, when they sent a thing to the moon, the first one was actually got on the bullock cart and everything, and see where we have now finally turned out to be. So we have a 55-year-old male who is a current smoker. He has come to us with a history of cough with expectoration, hemoptysis. CT scan showed a right lung mass with a hydral lymphadenopathy. Biopsy was small cell lung cancer, and we got a PET scan done, which basically showed a metabolic active soft tissue lesion along the segmental bronchi. Along with that, there were some hilar and subcranial lymph nodes, and there was also a lesion in the brain. So in the right parietal lobe, 2.2 to 2.0 centimeter, good amount of edema. This was the PET scan finding. See a very, very, very small lesion over here, actually nothing very significant. We got an MRI brain done, which basically said, there was again 2.5 by 2.5 centimeter lesion, which is query metastasis, query meningioma, and the radiologist's favorite words, clinical correlation is suggested. So what will you do? So a very small mass, otherwise a localized disease, and also has a lesion in the brain which they are not sure. Patient is absolutely asymptomatic. What will you do?
So I'll assume that the brain lesion is of primary lung only.
You will assume that the brain lesion is of primary lung only. Fantastic. Dr. Shailesh sir? And why will we assume this? Because it is okay.
I am not very sure whether on an MRI you cannot differentiate this. I think you should be able to differentiate
Sir,
between a
we just saw
meningioma.
the report of Rajiv Gandhi cancer, the lesser cousin of Tata Memorial.
I think I will take it as a metastasis.
Metastasis only. How about you?
Same.
Metastasis only.
Take it as metastatic.
Fantastic. So let us presume, Akhil, this is a metastasis. So you have a small lung lesion over here, which is potentially curable, and you have a single solitary lesion in the brain. Now what will you do? Do you want to start? Patient is absolutely asymptomatic. Do you want to start with systemic treatment upfront? You want to go ahead with whole brain RT? You want to do a cyber knife? Radiation oncology is very utavle for cyber knife, or surgery of the brain followed by SRS, followed by systemic treatment plus minus chemoimmuno, or anything which comes to your mind.
So what happens in this disease is that we know that this is a chemosensitive disease, and we want to treat it systemically as soon as possible.
Correct.
So what we do, we will try to start systemic treatment, and then definitely add treatment. It can be SRS, it can be anything. If patient doesn't have any symptom and there is no much edema, I think SRS is a good option.
इससे दो बातें मालूम चलती है कि तू अपने घर में बिल्कुल नहीं डरता. You don't want to send it for radiation. Okay, Chandrakant, what will you do?
Small cell, sir?
Small cell.
Agreed. Platinum first.
Platinum first. Fantastic. But since the patient had a perilesional edema, and the radiologist, we did discuss this case in tumor board, they were not sure whether it was a meningioma or this, and we wanted to change this. We actually underwent surgery of the brain lesion, and we were trying to be aggressive. It's a very small tumor here and this. We did discuss a lot in detail, and they said, nahi yaar, agar meningioma hoga, then you can actually go ahead and give CTRT to this. So that is where we felt probably we did surgery. It came as small cell CA lung. So let's start about small cell CA lung. Number of cycles. Chandrakant, I'll start with you only. 4 or 6?
If tolerating well, up to 6.
If tolerating well, up to. And who decides tolerability? Patient or us? So then 6 cycles. Okay, fantastic.
And also the response, like if there is a CR, the disease burden is low, then stop at 3 or 4.
So for the residents, I mean the difference between 4 to 6 basically is that whatever response you have to get, what Chandrakant said was right, you will get in the first 4 cycles. The additional response after 2 more cycles will not really come. So it is almost like, so what we do is, we also give 6, that is there. But we will see, after 4 cycles, if the patient has stable disease and the patient has good significant residual disease and the tolerability is okay, we'll go ahead with 2 more. Else we will say, okay, fine, 4 ho gaya and tolerability is not good. So that is what. But by and large, as long as you're given 4 cycles, it is absolutely okay. 6 may not be better, 4 is reasonably okay.
Sometimes if we are using with IO, then 4 is most of the time we tend
If
to
you're
stop.
using with IO, 4 is absolutely okay with that. Choice of platinum, what will you give your wife? Which platinum? Not this one. This one. Okay. So what platinum? I'm sure none of us know the various platinums differences in this. So cisplatin, carboplatin in a palliative setting, does it make a difference, or you're okay with etocarb?
Carbo is fine.
Carbo
Most of
is
the time
fine?
we are giving carbo, but we know that cisplatin is somewhat faster onset of action, but in the end
The
both are similar.
toxicity and all will
Yeah,
become. So by and large, there was not much difference between cisplatin and carboplatin. And I mean, again,
9% of our patients receive carbo.
I think, I mean, again, I'll put my hand up and say we give utopiazide carboplatin. It's very rarely that we give cisplatin to a patient. It's actually etocarb over there. You have tried many approaches. You can do extensive, you can give 3 drug, 2 drug, 4 drug, 1 drug, 6 drug, plus minus IO. Nothing basically works in this. So that is something which is there. So there was a study from Japan which says IO plus chemo is slightly better. Oh, sorry, irinotecan plus cisplat was better. But when you compared in a larger trial, this was not really found to be sufficient. So now we'll start with this. So not with you. So we'll start with here. Are you convinced with the role of immunotherapy in small cell lung cancer? Do you think it really works?
Yes.
Fantastic. And if you are not sitting in a Roche symposium, will you be convinced with the data of that?
Yes.
Yes, fantastic. Dr. Shailesh, sir.
Yes, in
Suppose the patient have to pay from his own pocket.
See, you have to tell the figures to the patient. You
So
know,
what
if you
will you
tell
tell
the
them?
figures of 10.3 and 12.3, let the patient take the call.
Okay. And how many patients take that call, sir?
None. They
So
will
if
tell
you
you
tell
what
the
is better. So, I mean, as per science, yes, I will go for it.
I think more importantly, I'm sure most of us will discuss the median OS advantage actually will not be more than 4 to 6 months, even in the or 10 months in the keynote trial. But what we do tell the patient is, if you respond, there is a 10 to 15% of patient who will be long-term survivors. The tail of the tail is something which we actually go back and tell the patient.
10% survival at 5 years.
10% survival at 5 years is something which is there. So this was the IMpower 133 trial data. 4 cycles of atezo-carbo, which was basically given. OS was improved. Again, important here is this 12-year survival of 51.7 versus 38.2. And more importantly, which I'm going to show you right now is, you know, Akhil was speaking right now and said, did we even think about a 6-year survival? So now I'll come to Dr. Vaman Dabar, sir. So you have more experience than all of us will combine together, sir. Did you even get a 6-year survival before the advent of immunotherapy, sir?
In small cell, I don't think so. I've ever seen a patient. I've ever seen.
So I think small cell, which was by and large at 18 months, 30 months survival, has now, we are thinking in terms of an overall survival also. And this was an umbrella A study. So what they did was, IMpower 133, people who were in the atezo-etocarb arm, so after 2 years or 3 years, when the Roche company wants to close the trial because they want to get the trial results published, they put them into an extension study. That extension study is basically called as umbrella A. That's called the rollover study, because then they are not a part of the trial. They just get the companion access or expanded access program. And what they basically found out was, I think they took 18 patients. So out of all these people initially, which was around 201, 18 people were eligible for this. What they basically found out was that there was nobody, you know, we always think liver mets hain, to isko jo hai wo survival nahi hoga. But if you look at here, there were 2 patients with liver mets and 2 patients with brain mets also who went on to the extension study. And what basically found out was something which is very, very good over here. A 5-year survival of 12%. Nothing great. This is almost like, say, CA pancreas surviving for 3 years. But then, you know, CA pancreas never used to survive for 10 to 12 months in our times or something. And again, this is a 6-year update. And if you look over here, a 3-year update, 16, 13, 12, 1. So if you actually go beyond that first 2-3 years, then probably you will be able to, survive for a long time. And this, to me, this is what I exactly tell the patient, that forget the numerical 2 months increase in the OS. It is the number of the tail which is going to be very, very important. Dr. Bhavan Daba, sir, impressed with these results?
Absolutely, absolutely. And at least a small percentage of patients will be surviving.
10% of people who can actually basically survive.
And without additional major toxicities that we see in practice.
Without toxicity, fantastic.
How to make these immunotherapy drugs more effective? That's the next.
The biomarkers study.
Microbiome.
You know, we have to bring in microbiome over there. Akhil should be renamed as Shah Rukh Khan of medical oncology, you know. Never miss a chance of promotion of microbiome and everything. Same here, Akhil. Okay, so there are many drugs, and this has not only happened with Atezo, it has happened with Durva also, although the only 3-year follow-up is there, and with Atezo we have a 6-year follow-up which is actually there. So, Dr. Chandrakant, can we now utter the C word, long-term cure or control in the context of small cell lung cancer also?
Well, it's impressive, 5 years has been crossed, and these patients are likely to live. So unlikely they will progress.
And just to put things into perspective, a subset analysis, and it just come to my mind, PDL1 negative people in Keynote 189, the 5-year survival is actually 9% adenocarcinoma. So it's 9% for PDL1 negative, 19% for 1 to 49, and 29% for more than 50. So by and large, if you give immuno, so my take is, when small cell lung cancer was being discussed initially 2 years back, I stood up and said I would want to give immunotherapy. They said for a 2 months OS advantage, why do you want to give? I think it's not the 2 months OS advantage, it is the potential for this long-term cure that is very, very important. The next step, as Dr. Akhil has rightly said, is we need to find the biomarkers for finding out which patients will really get this.
For the whole immunotherapy story, median is not the right way to judge it.
It's not the right way to
do it. It is a tail that is important.
We need to relook at the way we are doing. So this patient, our patient got surgery, then got SRS to the brain, then got after 4 cycles, he got a partial response to treatment over here. So now is where we have done the promotion for Roche. So we are done with that. Now let's come to science. Dr. Shailesh sir. Now the patient has a very small lesion, small lymph nodes over here, SRS to the surgery to the brain, SRS is over. Will you want to consider giving, and now that we know there is a data for Adriatic, we didn't know at that time, do you think we should go ahead and give thoracic consolidation RT also to this patient? And do you, I remember sir, 3-4 years back when my radiation oncologist actually told us to think about consolidated thoracic RT. I said, kya baat kar rahe ho yaar, small cell lung cancer, I mean, are you out of your job?
No, we should plan for a consolidation RT for this. But also important to note, we should keep a close observation on the lung toxicity, because the IO and everything is ongoing.
Correct. That goes without saying. So is the thoracic for you? Is the thoracic RT to a residual disease site being planned in your institute, or you just laugh it away like I did?
No, sir. So there is a data to show that it improves PFS.
So you are okay with giving thoracic RTs? Okay, we were the only one. Okay. So after you have got 4 cycles of IO chemo, we have this option. We can continue IO. We can give PCI and continuation of IO. PCI and thoracic RT, I don't know, PCI is not really the right word over here actually, because you already have a disease in the brain. I mean, that's the problem of being a medical oncologist. You want to overcomplicate things, So I don't know. So what we did again, so again we were discussing over there in the other session. What about Chandrakant, your thing about, do you give PCI to everyone? Forget this case over there. Let's say there's somebody with extensive stage small cell lung cancer. You're given 6 cycles of atezo, carbo, ito, and the patient is doing well. Do you go ahead and do a PCI, or do you do an MRI brain surveillance?
An extensive stage PCI.
PCI. Akhil?
If we are giving IO maintenance, then we don't usually give PCI, though it is allowed by the protocol of the trial, but we don't give
So why will not give?
So, in the era of IO, there is no trial of PCI which has shown any benefit till now, but there is no trial which has not shown benefit also. So that is also valid. But the thing is that if you are planning PCI, again, you need to plan hippocampal sparing PCI. That can be considered.
So what is the concern regarding PCI?
CNS toxicities basically.
The CNS, because now that the people are living more and more, so there is a growing body of thought which says that maybe 10-15% will live. So, but then no PCI doesn't mean that you call the patient in 6 months time and then get away the brain mets. You need to get a MRI brain done every 3 months and then
Japanese
go ahead
protocol.
with that. So what is your protocol, Dr. Shailesh? I mean, do you go ahead? We give PCI actually to everyone because it's slightly resistant to change now. But let's see how it goes. Yes.
I advise, because the number of patients of small cell VC is quite less. So, but I am a advisor to the PCI. Yeah.
What about thoracic RT? How many people?
We do.
You do thoracic RT to the residual, sir. Dr. Daba, sir?
If there is a residual disease, you should go ahead with thoracic
should
RT.
go ahead.
If there is a
When we are giving
residual
IO,
disease,
then we don't give thoracic RT. But
If you are
we
giving
not
IO, you don't want to give thoracic RT.
yeah, but since our 99% patients are not affording IO, most will end up, those who have good response will end up receiving
So
thoracic.
again, for medical oncologists, when I saw this data, we were also surprised that, why are you giving thoracic RT? I mean, honestly, small cell lung cancer was such a bad disease that by the time you finish off with 6 cycles and PCI, something will come back again. But there's actually a data that, you can give some thoracic RT too. If there's only an intrathoracic disease which is limiting and no pleural effusion, you can go ahead and give a thoracic RT. But then discuss with your radiation oncologist and make a plan. And all these plans have to be done prior and not at the end of this thing. So we can go ahead with that. This is exactly the patient which was, and this is, if you see here, this was the disease and we have given RT to him. This patient went ahead and actually got colitis, grade 2 colitis, and we had to stop medicine in between. And then he did not require, he just required some steroid enema and recovered. And now he's on atezolizumab maintenance at approximately around 2 years from the time that he has got this. So that is for all people that we used to think of, anybody who is this? Yeah, sir knows. This is Vicky Kaushal. This was small cell lung cancer like this before, and this is Vicky Kaushal right now. So हमारा number भी आएगा, ex-TMH, non-TMH वालों का number भी आएगा, and that is what I normally say. So this is our data of small cell lung cancer. We have given atezolizumab to around 35 patients. Brain mets were there in 8 people, absent in 27. ECOG PS was good in 23, 0 to do. 12 did not have. Good amount of disease control rate around 82%. Median PFS was 4.93, median OS was 10.5 months, which is probably because there were 12 patients with a PS of 3 and 4, that is also important. A 1 year OS of 43% and a 2 year, 18 months OS of 33% is something which is very, very, very important. And this is the graph that we have, this is the median OS of 10.5 and 4.3 that we are seeing. So it is not difficult to get the similar kind of results that you're getting in the long term. We have 4 patients now out of the 35 who are actually doing very, very good. So I think we should be considering immunotherapy in all the affordable and eligible patients with this. So that said about small cell lung cancer, and I think we have 5 more minutes. We have a patient who's a non-smoker, cervical lymphadenopathy, and was diagnosed with EGFR mutant non-small cell lung cancer. He got osimertinib after 18.6 months of PFS, because in the morning I also spoke about AZ, so we can't displease them also. So we will get exactly the same OS as was there in the trial, 18.6 months. The patient has progressed, and the systemic progression. We got an NGS done. There is no actionable mutation. What next? We'll start with this cycle. So what will you give to this patient, and what do you normally give?
If feasible, post-osimertinib progression, amivantamab plus chemotherapy.
Amivantamab plus chemotherapy, fantastic. And
if not,
and before amivantamab was available,
then one option is ABCP regimen.
ABCP is an option. So how do you decide between ABCP and Mariposa?
So Mariposa is only affordability.
Affordability is an issue. Dr. Shailesh sir?
I think if the patient has predominantly something like liver metastasis, I would go more for ABCP as compared to amivantamab plus chemo.
Okay. Your point?
Amivantamab plus chemo.
So we have 2 Mariposa and 1 ABCP.
What I have used in practice is ABCP mostly.
Is ABCP 3:1. Akhil?
Mariposa.
Mariposa 3:2. Chandrakant, you are the deciding one when we stop this. You can say ABCP and I'll stop right away. Else I'll have to discuss more data with that.
So as there is no, probably the NGS is good one, as there is no mutation, either the EGFR or a MET, and I would go for ABCP in
So
this
Chandrakant
patient.
has spared us of the ignominy of listening to my discussion point with some trial. Okay, so this is something which I showed you in the morning. Whenever you have resistance, look at the on target, look at the off target, look at the phenotypic transformation. So that is something which is very, very, very important. Please do a biopsy, that is very, very important. EGFR positive subgroup was tried in IM power 150, and there was an PFS benefit which was there. And this is not the only trial. The other trials are also there, which have basically shown that there is an increase in PFS and slightly increase in numerical increase in OS if you give a VEGF drug over there. So this was the patient who got 6 months of 4 drug and then 2 drug. The cost will become an issue. With ABCP, I think it is far more easier to manage over here. So what are the ideal patients? Akhil, I'll come to you for this. Is there an ideal patient? Maybe you will do a biopsy, and if it comes met, you will go more towards that. Or is the cost? How do you decide that?
So that's a valid. That's the only mechanism which we have. We know met alteration present go for drug which are able to inhibit.
Amivantamab or something over there.
Yes. But if there is no met, still
you can go ahead with Mariposa. So if you are no, sir. No. We are just presuming because that's a bispecific antibody. There is some retrospective cohort which says that somebody with a MET amplification will do slightly better. But if you have a MET amplification, you can actually give osimertinib plus savolitinib or a capmatinib also. So that is also a reasonably okay thing over there. So this is the one which I was showing on. If you look at all the trials, IM Power, 150 and Orient and Atlas and Harmony A, the PFS value actually for the IO plus anti-decay combination is actually better. I would say if there is any role of immunotherapy plus anti-angiogenic agent in EGFR mutant non-small cell lung cancer, this is here. This is the one where we should actually aim for. So just to
best
say,
is to enroll in a trial.
Best is to enroll in a clinical trial, and we have a trial coming up over there. So if you are in North, you can send it for RGCI. If you are rest anywhere in the world, you can send it to Tata Memorial Varanasi. Okay, so for me, there's a time, place for everything, and there's a place and time for Atezo, and there's a place and time for Bev in EGFR mutant non-small cell lung cancer also. With this, thank you. I have finished before time. Thank you. Thanks a ton.
Thank you.